everyone, and welcome to the first lecture of the Myopia Action Month 2025 Clinical Clarity Lecture Series. My name is Jeanne Saw. I'm an optometrist and I'm Manager of Professional Affairs and Partnerships at Myopia Profile. Today we're going through strategies for providing effective myopia management from clinical testing all the way to communication. Now I would like to start off by acknowledging that childhood myopia management isn't just a nice to have, it is recognized globally as the standard of care. The World Council of Optometry and the World Society of Pediatric Ophthalmology and Strabismus have both published guidance emphasizing the importance of proactive myopia management, which sets clear expectations for us in clinical practice. If you'd like to read these in full, the QR codes on screen will take you directly to these documents. Now, why is it considered the standard of care? One key reason is that there is no level of myopia that is considered safe. Even at relatively low levels, the risk of sight-threatening eye conditions is increased. This data shows that keeping myopia below -3 diopters significantly reduces the lifetime risk of these conditions. The same principle applies when we look at axial length. Here we can see that there is a clear relationship between increasing axial length and the risk of visual impairment by age 75. That's why, just as we aim to keep refractive error below -3 diopters, we should also aim to keep axial length below 26 millimeters. So really, our goals in myopia management are twofold. We want to slow the change in prescription and slow the growth of the eye itself. Now, what does that mean for the tests we do in practice? Let's go through the key ones. So the good news is you probably already have most of the tools and skills you need for myopia management. It's really about applying them in a structured way. So of course we start with a thorough history, then we move on to getting an acuity and an accurate refraction, then binocular vision and accommodative testing. For ocular health, we assess both the anterior and the posterior segments. Now that might mean including intraocular pressure testing, corneal topography, and or a dilated retinal exam where indicated. If you have access, axial length measurement is extremely valuable, but of course you can still provide myopia management without this. Now for a complete breakdown of these recommendations and an understanding of when certain tests are indicated, you can scan the QR code to read our full article on clinical testing on myopiaprofile.com. Now this will vary based on your scope and setting of practice. Not everyone might have access to cycloplegic agents, but if you do have access, there is consensus on advice from the American Optometric Association and Optometry Australia that cycloplegic refraction is recommended in the presence of conditions like strabismus, amblyopia, or anisometropia. The International Myopia Institute defines myopia by refraction as when ocular accommodation is relaxed, and accommodation can also be managed with techniques like fogging when cycloplegia isn't an option. Okay, so testing and diagnosis are only half the story. The other half is helping parents understand what myopia means for their child and why management matters. Some key messages for parents when it comes to myopia control, and they don't need to take a lot to explain, can really help frame the conversation. So we can explain that myopia is growing in prevalence around the world. It is a progressive or worsening condition in children, so it will change. And it's more consequential than just a pair of glasses because of changes in vision, making vision less stable, and also those increased eye health risks later in life. But it is manageable with treatments to slow progression. So the important thing to note in all this is that we want to reduce the risk of vision impairment, both short term and ultimately in the long run. And you can phrase those benefits like this. You could start by outlining the short-term benefits of myopia control first, as these are often immediately accessible to people. and then highlight the longer term benefits later on. This chart here summarizes meta-analysis data on progression in children wearing single vision correction. You can see that the average 7-year-old progresses by at least 1 diopter per year, while the average 12-year-old progresses around half a diopter per year, with some still reaching almost 1 diopter of progression per year in those 12-year-olds. Because younger children progress the fastest, every year without treatment represents a lost opportunity to save 1 diopter and to reduce long-term eye health risks. Myopia control then should begin as soon as possible in all children under 16, and particularly in those under 12, we want to avoid the wait and see approach. And now we have a lot of options available to us for myopia management. There are a variety of myopia controlling spectacle lenses that are on the market now, as well as soft contact lenses and ortho-K, various concentrations of atropine, and there are also light-based therapies that are being studied too. You can learn more about these throughout the lectures in Myopia Action Month this year. Look out for my colleague Brian Peng's lecture in week 3 on optical interventions, and Dr. Kate Gifford's lecture in week 4 with the latest on atropine. The Myopia Profile Managing Myopia Guidelines infographics are a great tool to support the entire communication process, but I'd just like to point out on side 2, which is the practitioner chairside reference, which includes comparisons of the treatments I've showed you in the previous slide. Now you can download the full infographic, which is available in 20 languages, using the QR code on the slide, or you can visit myopiaprofile.com. Okay, so where to start? And as an optometrist, it makes sense to me to prescribe optical treatments first, because they provide the dual benefit of myopia correction and myopia control. And so the question might become spectacles or contact lenses. With myopia control spectacle lenses, they offer the highest safety profile. They are suitable for children of all ages and they accommodate a wide range of prescriptions. But on the other hand, studies do show that children wearing contact lenses feel more confident in sports, social settings, and overall daily activities. So a lot of pros to consider for both. What you can say when you're starting to discuss the different treatment options is that there are special spectacles and contact lenses that can both correct myopia and slow down its worsening. Special eye drops can also help, although your child will still need glasses or contact lenses as well to see clearly. Okay, I'm going to finish up now by pointing you to some resources to help you learn more and to support you in putting this into practice. Myopiaprofile.com is designed for eye care professional education, and mykidsvision.org is our public awareness website, which helps to educate patients and parents about myopia management. On myopiaprofile.com, you'll find clinical articles, science summaries, downloadable tools, all focused on helping you implement evidence-based myopia management in practice. Now you can explore the site or scan the QR code here, and follow us on social media if you'd like ongoing updates and tips. On the website, here you can find our online courses. We have some new Made Simple courses as well, which are designed to be 1 hour long, and it gives you the essentials on a variety of different topics. And the resources tab will take you to our infographics, brochures, and more. mykidsvision.org is designed for parents. It's a free, easy to understand website that explains what myopia is, why progression matters, and what treatment options are available. You can download our QR code cheat sheet, which makes it easy for parents to scan during a consult to take them directly to these articles. Now that brings me to the end of my lecture. Thank you all so much for your time and attention, and I hope you enjoy the rest of the Myopia Action Month Clinical Clarity lecture series.